caries, and perio. So this is the meat of what we do. And I know that we had talked last week about finding some sites where you could actually practice identifying caries. The one site that I went to was dentistry.uiowa.edu. If you go to Iowa, to that site, you can put in dental case studies or caries case studies. And I know that many of the schools that have dental schools have some really great case studies. Another place that you might look to practice those skills is on dentalcare.com. They have case studies for students, and I would imagine that they would have something like that as well too. I'm going to keep looking if I can. I used to have a really great site that had, I don't even know, like 35 case studies, and I don't know what they've done to it. I don't seem able to access it anymore. So I do think I printed it off in a worksheet form though, so I might bring that in if I can find it. And it's not the same as having it online and you can interact with it. So I would try the University of Iowa, and like I said, you just put dentistry.uiowa.edu, and in the search bar, look for dental case studies or caries case studies and see what you can find. Okay, so today we're going to describe what caries and how, what dental caries and caries detection looks like. We're going to interpret, and we'll talk about some tips and factors that can influence that interpretation, and introduce the different classifications of caries, which you probably have had a touch of that in 101. So description of caries is just basically tooth decay or cavity. It's a localized destruction of a tooth by microorganisms. And if you look at this image, they are shining the mirror on the upper arch, and you can see that there is a cavitation or a hole in that occlusal surface. Sometimes it won't look so obvious. Sometimes the occlusal surface won't be broken, but you can almost see kind of a shadow under the surface, and you maybe won't see that until you take an x-ray or know for sure. But when you see those shadows kind of down under the enamel, it always makes me suspicious of decay. You can see in this first image what I'm talking about. That premolar, you can see there's kind of a radiolucency, and then there's kind of a shadow on that mesial side of the tooth. So that's kind of what we're talking about. If you look at the x-ray, the bite wing, and you look on the upper between tooth number, that would be 14 and 13. If you look at the enamel, you can kind of see that triangulation of radiolucency that's starting. And always remember that decay on an x-ray is usually not as bad as it is when a doctor goes in and opens it up. Many times when we get into the tooth and open it up, that decay goes further than what we think it does on x-ray, because we don't have depth on an x-ray. We only have 2D representation of a 3D object, so many times it's worse than what we think. If you look on the lower molars, between 18 and 19, especially the distal of 19, you can see that little radiolucent ditched out area. That's probably, well, no, that is decay. If you come into the enamel, to the dentin between the enamel and that filling, which is probably an amalgam, you can see kind of a radiolucent round area. That, I would guess that decay is into the dentin and is probably far worse than what we think. So that's kind of what we're looking for. So to detect caries, it's not only important to have our x-rays, it's also important to do a clinical exam and be thorough about that. Dental images will enable us to identify those lesions that we can't see clinically, and they allow us also to evaluate the extent and severity. So sometimes we might look in the mouth, we might see that little shadow, And then we take an x-ray, and you can see on x-ray that it is into the dentin, and it, as I just stated, many times is worse than what our x-rays actually show us. Some carious lesions, like I said, can be detected clinically. The best tool is to use your mirror and to reflect that light, allow for indirect vision, and retract the tongue. Use your air. Air is huge. I cannot tell you how important that is when you're, especially when you're restorative charting. The new composites are so difficult to detect. I have to rely on air, my mirror, the light, and x-rays many times. And even then, sometimes I'm asking the doctor, do you think that's a composite or not? Because they just blend so well. Like I said, color changes can be observed. Sometimes the occlusal surfaces can show dark staining in the fissures and pits. However, I will tell you, when I started working as a hygienist, I worked for a doctor, and he put like a grocery list little notepad, the long skinny notepads, by our chair with a pen. And he wanted me to note every single dark groove, dark pit, anything on the tooth, and he wanted to fill every single one of those. There are so many of us that have bad habits like coffee, pop, tea, smokers, anything that's stained, red wine, that can get down in those grooves over time if it's a repetitive habit. And that doesn't necessarily mean I have decay in those grooves. Those grooves could just be stained. If they're just stained, I don't need to go in and drill and fill every single dark groove in someone's mouth. Needless to say, I only worked there for about 3 weeks, and I was out because I did not ethically believe in what he was doing. So not every dark groove, pit, and fissure is decay. Smooth surfaces can exhibit that chalky white spot like we saw on that one image where the premolar on that mesial kind of had a chalky spot and a dark shadow. So those are all kind of things that you'll learn to look for. Interproximals, as we know, can be very difficult to tell with the naked eye if there's decay there. That's why bite wings are so important. And always remember, bite wings are the image of choice for interproximal decay. Some teeth, like I said, can exhibit that discolored area or cavitation, and some have no visible changes. You don't know it till you take the x-ray. The areas between the teeth are sometimes impossible to detect clinically. So that's why these dental images play such an important role in these situations. And that's why doctors get really frustrated if our bite wings do not show open contacts. So we want to definitely be working on that skill of opening those contacts. And to do that, it is always going to be a horizontal error. And I would always look at my image receptor to tooth relationship. We always tend to want to adjust our aiming ring or our tube head horizontally. It does not matter what you do with the tube head outside the mouth if your sensor or PSP plate or film is not in alignment in that parallel relationship with the teeth. So the very first thing I would encourage you to do if you've got overlap is watch when you place your sensor and make sure that you hold it in place as your patient closes so that it maintains a parallel relationship with that arch. A carious lesion is going to appear radiolucent, obviously, and that occurs because it has a decreased density, the tooth itself. Part of the tooth is being eaten away or it's much softer, so x-rays will travel through that easier than they will solid tooth structure. So like I said, bite wing images are going to provide the greatest amount of diagnostic information. A periapical can be helpful if it's taken using the paralleling technique. So sometimes those also can be helpful, but bite wing is the image of choice. On this x-ray, you can see that decay between the premolars. And if you look at tooth number 13 that the arrow is pointing to, you can see the shadow under that enamel outline. That would tell me that that decay goes pretty well into that dentin. If you look at the lower, again, it's that triangulation that we see on number 20 distal. And it's actually probably into the dentin. On that x-ray, it looks like it just comes to the border of the enamel, but I bet you when that's opened up, I bet you it's into the dentin. So we'll talk about some tips for interpretation and some factors that can influence our interpretation. Number one, proper mounting. We want to make sure that we have those x-rays in either the digital chart or the digital mount, or if they're film, in the correct order. We want to make sure that we view them with low light, free of distractions. It helps too with a computer if you can even do that. So if you've got your computer in your room and you're trying to do some interpretation, turn the light off and just look at your monitor, because sometimes that helps. And some of those mounts I showed you are dark, and that's to mask the light that comes in around film. And then magnifying glass, or the magnifier in our software, which I've played around with in lab with you guys a little bit. And if I haven't, ask me about that and I'll show you those tools. Dental images should always be viewed with your patient present, because if we find something or interpret something and then have the doctor validate that, we want that to happen before that patient walks out of our office, so that we can either get them scheduled to get that taken care of, or referred if we need to refer them. Dental images must be of diagnostic quality. So we've talked about these errors, and I try to keep reiterating that in lab. I want you guys to feel confident if you've made an error, to know what changes you need to make to correct it. So if you've got overlap, it's horizontal angulation, and that's usually due to sensor placement in regards to its relationship to the teeth of interest. So we need that parallel relationship. If it's elongation or foreshortening, it's going to be vertical angulation. If we have an error in exposure, contrast would be KVP, density would be MA or time. So I want you guys to feel confident in knowing what changes you need to make if there's an error made. And the classification of caries. So we have interproximal, occlusal, buccal and lingual caries, root surface caries, recurrent caries, and rampant caries. Interproximal, you guys know very well. It's between two adjacent tooth surfaces, typically at or just below the contact point of the teeth. And it typically assumes that triangular configuration as it kind of works its way through the enamel to the dentin. When decay reaches that DEJ, it'll spread laterally and progress through the dentin. It's like it hits the dentin and then just kind of blows up. Carious lesions are going to be classified as either incipient, moderate, advanced, or severe. All of these classifications have kind of a definition that would define each classification, and we're going to go over that. So if I have incipient, this is where we want to catch our patients. Sometimes you can just see the little bitty starts. As you look at this image, it's not through the enamel, it's just at the start. And in today's world, we're very lucky that we have many great new dentifrices that are remineralizing. So Enamelon is one. I'm pretty sure Sensodyne makes one. Remen, I think, is another one. So these are basically toothpaste that incorporate phosphorus, calcium, fluoride, and if you catch somebody at the incipient stage and you get them using these and flossing and changing their home care, these areas can actually remineralize and never actually reach a point where they have to be filled. So incipient is just that very, very beginning start. It's going to extend less than halfway through the thickness of the enamel. It would be seen, like I said, only in the enamel, and on x-rays, they're just the tiniest little thing. That's why I love my magnifier, because I can hover right over that if I've got nice open contacts on my x-rays, and you can see the little bitty itty bitty starts. And that's when you want to get a hold of your patient and get them changing things so they don't end up with a whole mouthful of fillings. In moderate interproximal caries, it's going to extend more than halfway through the enamel, but it does not yet reach the dental enamel junction. So this would be a moderate class 2 lesion that you see here. This would require a filling. Advanced, now we're extended to or through the DEJ and into the dentin, but it is less than half the distance in towards the pulp. So as you can see here, they've kind of outlined this one in red, both of these. So you can see they're into the dentin, but they're less than halfway to that pulp chamber. And then severe extends through the enamel and the dentin, and it's more than half the distance towards the pulp. So this is severe. It's going to involve both enamel and dentin. Clinically, you're going to see this. You're going to see the cavitation if you look in the mouth. Occlusal caries, it is the most common type of caries that we see, especially in kiddos, because unfortunately we like to eat candy and sweets, and our occlusal surfaces of our molars and premolars many times are very groovy and deep, and chewy sweet things will stick in our occlusal surfaces. And if we're not removing them or neutralizing those sweet things with foods that would reduce the pH of our mouth or would neutralize the pH of our mouth, then caries can occur, and it often does. So the bad thing about occlusal caries is they're very hard to detect on X-ray. When you look at the occlusal surface, we've got all of these cusps, and they kind of superimpose themselves on each other when we take an X-ray. So the decay has to be pretty deep into that occlusal surface, almost through the enamel, before we can actually see them on an X-ray. So for occlusal caries, we're going to rely on clinical exam and our X-rays. If we look at this image, you see these stained areas that the arrows are pointing to, and then this little incipient caries that it's pointing to. Just looking at that tooth, you would not know that one little spot over here is actually the start of decay, and these are not worrisome at all. They're just stained. I don't think that when I was in school, we would take our Explorer and we would explore down into those grooves and feel for catches and sticky spots. Typically, I think that they are recommending now that hygienists don't do a lot of that, because we don't want to break surfaces that could possibly have been okay had we not invaded them. So I think we just kind of drag our Explorer through, and if it catches on something, fine, but you don't want to like poke into those surfaces. This one little incipient caries that this is pointing to, if we took an X-ray, you wouldn't see it. It would be superimposed by all of the cusps, and you would not know. So moderate occlusal caries is where we can probably start to actually see it on an X-ray. You can see the arrow on this premolar. See how the cusps overlie one another, and you can't, it's so radiopaque because of the dense cusps. The decay is in that surface, but it had to get all the way through the enamel and down into that dentin before we could actually see it on a dental image. And then severe occlusal caries obviously is going to extend into that dentin, and it's going to appear as a huge radiolucency. You've probably heard people say it was a blown out tooth or something like that. So that's severe occlusal caries. Buccal and lingual caries. Many of our, well, especially on molars, you'll see the buccal pit or lingual pit where those grooves come. There's that groove that runs right down the buccal or lingual, and many times when the tooth is forming, those can be kind of exaggerated grooves and tend to end up causing decay there because it's a hard area to keep clean and things want to stick in there. Bacteria can harbor down in those deep grooves. So you'll see these buccal or lingual caries. And usually if you look, someone's got a buccal pit or a lingual pit, it's a little round area where they've filled it either with amalgam or composite. Very common, but they're very difficult to detect on a dental image because, again, they're superimposed on tooth structure. If they're visible, they're going to appear as this little circle or radiolucent area that you see on this premolar here. Root surface caries are going to become very common in your older patients. And the reason for that is as we age, we see recession. The gums start to recede, and our root surface is not covered with enamel like the crown of the tooth. So you've got vulnerable tooth surface that's just dentin, covered with a little cementum. So it's way more prone to decay. So also another thing we see with our older patients is dry mouth because of all of the medications they take. And just as people age, many times they have a decrease in saliva flow anyway. So if we have a decrease in saliva flow or xerostomia, that's the cleansing mechanism that our body has for our teeth. So many times the root surface becomes very vulnerable to decay. What do people do when they have dry mouth? They start sucking on candies and drinking fluids, and they don't always choose water or things that would be the better choice. They choose pop or things that can break down tooth surface. So root surface caries are going to be very common in your older patients. They appear as a little cupped out area or crater-shaped radiolucency right below the CEJ. You can see where these arrows are pointing, and they're kind of showing you that radiolucency right below that CEJ. Again, early lesions in root surface caries are difficult to detect on X-ray, but if you get in the mouth and you do a clinical exam, you can see them because there's recession and the root is exposed. Here is recurrent caries. It's reoccurring. It is occurring under or adjacent to an existing restoration. If you look at this crown, you can see the big radiolucency right underneath it. So that tooth was restored, and for whatever reason, bacteria was able to get in under that tooth. Maybe they were unable to keep that area clean, and now we have recurrent decay. Rampant decay, you're going to see this in your soda pop drinkers. You're going to see this in people that are unfortunately addicted to methamphetamines, things like that. This is advanced severe caries, and it's going to affect a number of teeth. We see this in children that have poor diets and aren't good brushers, adults, again, with severe decreased saliva flow. And again, soda is the big one. And sometimes people don't even think about that. Maybe they're consuming tea and they think tea is natural and it's healthy, but they're putting, 3 teaspoons of sugar in every glass of tea, and we're drinking it all day long. The other thing with a sugar-full drink, or even acidic, we had a patient in our office that was, a Diet Coke drinker. Diet Coke still contains acid. Acid is not good for the teeth either. And if you're bathing your teeth in that all day long, that can cause decay. So those are all things to think about if you have a patient that presents with rampant or severe decay like this. Conditions that could resemble caries. So this would be where interpretation gets kind of tricky. And this first one, the cervical burnout, this to me, when I first started in dentistry, I think I mentioned to you guys that the dentist I worked for was wonderful with teaching me how to interpret. And the cervical burnout was something that I thought every single one of my patients had root caries because it looked like root caries, but it wasn't. It was the cervical burnout. So what that is it's a radiolucent artifact that is often seen on dental images, and it'll appear like a little collar or wedge-shaped area at that CEJ right by the alveolar bone. It can also appear as an ill-defined wedge-shaped radiolucency on the mesial or distal root surfaces near that CEJ of posterior teeth. And this is what it looks like. So if you see where all these arrows are pointing on these teeth, right at that CEJ, this patient does not exhibit recession. So we don't have root exposure, but it looks a little radiolucent right there. And what's happening, if you look at this tooth, the kind of cartoon drawing, as if you sliced the tooth in half, and those two brown dots are the root canals that are running down into the root structure. As those x-rays come through, there's the natural groove on the mesial and distal of that tooth. There's not as much enamel or dentin or tooth structure there. So when you take that x-ray, it does not appear as radiopaque as the rest of the tooth. And that is actually cervical burnout, not decay. And you think, well, how do I know? That's what I thought too. Well, when you get in the mouth, you would be able to take your Explorer and feel around all these areas, and you would not feel any decay. So that's how you know. But just be aware that cervical burnout does resemble root caries. Restorative materials, we've talked about the older composites. How do I know whether it's a composite or whether that's decay? Well, the composites would be prepped in a nice, perfect little round area, and you could, 9 times out of 10, they were on anterior teeth, because back when the older composites were used, we didn't use them very much in posterior teeth. We were all about amalgam then. So typically these older composites are going to be seen on anterior teeth. Also, they used silicates and acrylics that could also appear more radiolucent like caries. So you'll have to rely on clinical and x-ray. So you'll kind of go back and forth between the mouth and then looking at your x-rays. And I think, let's see. Yeah, I think that pretty much just the composites, acrylics, and silicates can look that way. And here's an example of composite. You can see on some of these anterior teeth, we've got newer composite that looks more radiopaque on these x-rays. And then you see these perfectly shaped little half moon radiolucent composites that are older. Attrition is the actual wearing down of teeth. When people are grinding their teeth or using a toothbrush that's too hard and scrubbing it, any of those things are mechanical actions that can cause the wearing away of tooth structure. We can see this on the occlusal or incisal surfaces. You can see this at the gum line. If somebody is scrubbing their tooth way too hard, we can see ditching at the margin. So clinical exam is going to enable you to see this, but on x-ray, you could see kind of a radiolucency where we've worn tooth structure away, and you might think it's caries. So this one is showing you incisal edge attrition. So you can see how there's that little line of radiolucency where those arrows are pointing. You could get in the mouth and you could clinically see that that's not decay. It's where the enamel is worn away. Abrasion is more what I was talking about at the gum line. So this is wearing of tooth structure due to friction of a foreign object. The surface affected will depend on the factor, like what you're doing. Most frequently, it's due to that improper brushing with a hard toothbrush. It will appear as a highly polished defect in the dentin. It should not be confused with root caries. Root caries will appear brown and leathery when you look at it, where this is smooth and the dentin almost looks like you've polished it. So if you look at this premolar with these little tiny red arrows pointing, you can see that radiolucent kind of halo right there. If you went in the mouth and looked at that, that's actually kind of a ditch where they have scrubbed away tooth structure. So there's not as much tooth structure there anymore. So that's why it appears more radiolucent, because the x-rays don't have to travel through as much structure. I think you guys have seen this before, the GV Black caries identification classification. So a class 1 is your occlusal. A class 2 is going to be your proximal surfaces, your mesial or distal, and that's going to be referring to premolars or molars. Class 3 is proximal surfaces of central incisors, lateral incisors, and cuspids, not involving your incisal edges. Class 4 is going to be proximal, including the incisal edges, as you can see right here in the anterior teeth. Class 5 is often done not only for caries, but that abrasion that I showed you where a person scrubs and actually abrades tooth structure away. If that becomes too deep and maybe they're having sensitivity or concerns, or maybe the doctor just wants to cover that to prevent further wearing or possible decay because things can trap in there, they'll do a class 5 composite now to kind of cover that up and protect that area from further wear or decay. And then class 6 are the cusp tips of molars, premolars, and cuspids that you can see right here. I just put this image in because I think this is nice to have to compare the stages, the illustration with the radiograph, so you'd kind of know what you're looking at on a radiograph and what stage of the game you'd be in if you were seeing a tooth like the examples here. Okay, does anybody have anything they want to share or any questions about that chapter?
So the remineralization things that you were talking about, like the